Our next speaker is Dr. Sanjay Chandrasekaran. He is a medical oncologist here who specializes in ocular melanoma. So he's going to give us an excellent talk about being in the clinic with ocular melanoma.
All right, great. I think so. Everybody rested from their break and hydrated and maybe got some coffee. So we're going to shift gears a little bit into something a little different than what we've been talking about. These are my disclosures. So, if you had asked me when I was a fellow, am I going to be interested in ocular melanoma? Is this something that I'm going to be spending my time with patients and research and clinical trials? And I would not have known. This is almost, it's quite rare in a way. And to me, it's a bit of a Waldo story. If you're really curious, he's there. But, it kind of was happenstance in terms of how this came about. But, the eye has melanocytes, believe it or not. And they're actually not just in the front where we think the eyeball is, and that's the colored part. They're actually there throughout most of that posterior structure. The ACS, or American Cancer Society, projects there'll be about 100 to 105,000 cases of invasive melanoma across the board this year in the U.S., and 5% of those will be uveal melanoma cases. If we look across the board, though, of all ocular melanomas, which also include melanomas of the orbit, melanomas of the eyelid, or the conjunctiva, then it makes up about 90% of all ocular melanomas. And there's really three structures as a part of the uvea of the eye. There's the choroid, there is the ciliary body. Oh, great, we have a pointer. And an iris. And most of the choroid is really running all the way through around the posterior part of the eye. And that 90% of the uveal cases are coming from the choroid. The challenge here is that these can live hidden. They can hang out in the back. Patients may not notice them. They generally require some kind of a retinal imaging to actually look through the pupil and then scan the back of the eye to detect these lesions. This is a photo of an actual pigmented lesion, uveal melanoma, from one of our world-renowned ophthalmologists. And some symptoms that you can see, and I say possible because in reality, a lot of these are quite non-specific. Blurry vision, distorted vision, maybe just complete loss of vision in one eye, that curtain or shadow effect that we describe, having floaters or flashes, change in the shape of the pupil. And then the most obvious one is if you have an anterior iris melanoma that will actually, in somebody who's very light-eyed, light blue, light green, you might actually see the pigmented lesion on the front. But as I mentioned, iris cases are pretty rare. So what are the risk factors here? So patients always ask, is it that I was in the sun too much? Is it those Cheetos that I ate when I was a kid? Or maybe, I do a lot of machining at home, or maybe it's just the people I choose to socialize with. And Dr. Gill went through all these risk factors for skin melanoma, and unfortunately or fortunately with uveal, this is really not true. We just don't have great screening risk factors that we can rely on. There are some trends, which I'll kind of address. So men greater than women, older age, over 60. Again, not necessarily, they're really neither here nor there. We don't make decisions based off of this or screening decisions. We do see trends towards folks who have fair-colored skin, lighter eyes, so this really Northern European phenotype where we have a slight predominance, but uveal melanoma can actually affect anybody of any kind of ethnic descent. And in terms of genetics, we have kind of well-known syndromes, but they're very rare. So about 2 to 3% of cases associated with inherited genes. The most common one is a protein called BAP1. So the biology of uveal melanoma is really different. Dr. Wang gave this great talk on BRAF/MEK and the V600E and V600K mutations that we see. And these kinds of alterations that fall in the MAPK pathway for skin melanoma do not occur in uveal melanoma. The target genes are quite different, proteins in GNA11 and GNAQ. And that impacts not only how the disease grows, how it spreads, what it does, where it goes, but also the kinds of treatment approaches. With skin melanoma, We talked about lymph nodes extensively. We don't really look in uveal melanoma for lymph nodes. This disease does not move into the lymph node drainage and then to other places. It goes straight into the bloodstream. It's notoriously has that capacity, and the liver is basically a sanctuary site. 90% of distant disease will end up in the liver. And as I mentioned, again, the treatment approaches are quite different. So the genomic landscape of uveal melanoma is really important. It's been an evolving science over the last 10 to 15 years. Our chair of ophthalmology here, Dr. Bill Harbour, and many of his great colleagues have been pioneering this science. Really, it's to understand, and now we do understand, how do you go from just a completely normal pigmented melanocyte in the back of the eye, have mutations that show up in that melanocyte, and then it becomes more and more active over time. It goes from being benign into a low-grade pigmented lesion that maybe you don't have to do anything about, to eventually progressing into a true melanoma that either has higher or lower risk features and higher or lower risk for metastasizing. What we know now is that there are really two major factors that contribute to the risk of spreading disease. So this was published earlier this year. This was an incredible amount of work through an ocular cooperative group, almost 26 different centers that participate, 1,500 uveal melanoma patients that contributed their experiences and their science to developing this data. And what we know is that we can send for gene expression profiling and we get a class, or class 1 or class 2, a low risk versus a high risk. We can also look for the expression of a protein called PRAME. This is very specifically expressed and is known in uveal melanoma, if expressed, to contribute to its ability to spread. And putting those two together, you can get a curve like this, where you can see a low-risk disease where it's class 1 on expression profiling and not expressing PRAME, to something that is very high risk for spreading within the 5-year period with class 2 or PRAME expression. What we also know through this data and other smaller studies, this is probably one of the largest ones out there. If we look at the prevalence by class or risk, about 50% of the uveal melanomas are on that low risk class 1 PRAME negative, and then the rest fall in the higher risk where they're either class 2 or have PRAME or both. So this is, in the focus of the talk, we'll kind of shift gears. We covered a little bit of the biology, but really this is an overview of what it's like to be a patient and how do you move through, who do you see, and who's going to be involved in your care. And as a theme that you've probably commonly seen today, it is multidisciplinary. So when you get that initial diagnosis, you have vision changes, a patient goes in and says, hey, I have blurry vision, an optometrist or maybe an ophthalmologist looks in the eye, a concerning pigmented lesion is seen. You should be referred to an ocular specialist. This is an individual who will be able to do an ultrasound, measure the size of the tumor, and then guide further local therapy management. Local therapy can be in two forms, either through radiation or a surgery through an oculoplastic surgeon. The goal of this is to kill all those cancer cells in the eye so that the disease cannot spread. At the same time, we strongly recommend now getting a biopsy done. The biopsy here is, again, not to prove that it's a uveal melanoma. That is largely a clinical diagnosis. The biopsy is to get that gene expression profiling and PRAME data, because that's what, as I showed in that last curve, affects how do we think about what's the risk of this disease spreading? Where would that patient's disease fall in terms of risk stratification? And based on that information, a medical oncologist like myself would be able to discuss, this is how we want to do scans and surveil for recurrence, or are there any trials that are available that might prevent or seeking to learn how to prevent the disease from spreading? The local treatments are very effective, up to 5 years. Most of these are over 90% effective in preventing a local occurrence. Again, this is in the eye. Radiation oncologists get involved. They work with the ophthalmologist. They place a very small plaque on the tumor. That tumor is then killed off. The plaque is removed, and then patients are monitored. The alternate option as you can imagine, is a surgery if the tumor is large enough and a plaque cannot be placed. So it is, I did try to find a nice graphic, but they're quite not lunch friendly, so we'll go with Etsy. But you get the point. It would be extensive, and it's not to make light. It truly is a life-altering decision to have to undergo an enucleation. What happens next is largely in my clinic, where I see patients and talk about surveillance monitoring. These are our national guidelines. I'm highlighting basically that we think about things now through risk stratification. How often do you need to do scans based on the risk of something showing up, which is based on the biology of that patient's particular tumor? Some general comments to this, as we have folks from here locally, but also just multiple other centers and also folks from around the globe that are listening in, is that as far as the science goes, there are no known approved or truly effective adjuvant therapies that are broadly endorsed. This means that after you've had your primary treatment to the eye, that you should do 1 or 2 or 3 years of some kind of treatment. That does not exist at this time. Work is being done, but it doesn't exist. Liver imaging is a top priority, as 90% of the disease will show up, or metastases show up in the liver. The type of scan used is going to depend on a lot of things. It depends on the provider preference, the country that you're in, how much it costs, what are the resources to get that type of scan, or even just the treatment center where you are and their preferences or their technical expertise. So effectively, something should be done, and it should be done longitudinally. It shouldn't be a one and done. And this is because, kind of reiterating that curve, there are folks who have at the 6, 7, 8 year mark late recurrences of disease. So we don't want to just do 1 or 2 years of surveillance and then let patients go. The approach to treatment, and I'll just go as an overview. I don't talk about side effects because that would take another 40 minutes and then we would be in the lunch. But effectively, there are different modalities that are available. So the liver-focused or directed options, we have approved agents in this space, and we have also clinical trials that are exploring further options here. There are immunotherapies, which we've talked about. We have approved agents, largely pulled from skin melanoma, other clinical trials, and then also looking at the HLA status of a patient to determine which kind of immunotherapies are best. There are cellular therapy options. We'll talk, it comes from skin melanoma, but we've adopted some of that over to uveal and other further clinical trials in that space. Targeted therapies, a little bit different than the BRAF and MEK inhibitors that Dr. Wang had talked about, still in clinical trial phase, and then less often used, but often still brought up as a consideration, are more conventional chemotherapies. So if we think a little bit about the liver-focused or directed treatments, you can really put these in sort of 2 groups. You have the ablative approaches, so if there's a single site of involvement, maybe you can just cut that out or ablate that single site, or use something like external beam radiation to treat that site. When the involvement of the disease is more multifocal or larger and you cannot completely treat that area or resect it, we use embolic and non-embolic approaches. This is using the vascular structure of the liver. The liver is basically a filter for your body, everything kind of moving through there. So it's a unique way and a very liver-specific way to be able to put a catheter into the liver and then treat using the vascular structure. And the embolic approaches are either to push chemo into one of the branch stems of the liver. You can also do immunotherapy agents or beads, radiotherapy beads. And then the one that has been adopted and has become more, was recently approved in the US in the last 2 years, is a perfusion-based approach. And we'll specifically kind of talk about PHP, or percutaneous hepatic perfusion. So this is an FDA-approved treatment here in the U.S. now, and what it is involved to a degree. The liver vascular supply is isolated in an operating room with a whole team of anesthesiologists and possibly a surgeon or a radiologist, and chemotherapy is infused directly into the liver. You're basically bathing the entire liver vasculature with this chemo, melphalan. That chemo, then whatever is not kept in the liver is then captured on the way back out. And these patients are then monitored afterwards for, just because of the risk and the vascular cannulation side effects and other things related to this treatment. But it is a very much so, I think, a full-on liver-directed approach. There are some approaches in trials as well. This is just one example. It's called SD101. It is actually a combination of a device and an immunotherapy. They're targeting a mechanistic pathway called the toll-like receptor 9 pathway to drive immune cells to come into the liver and start working against the melanoma. And it even fights some of the cells that are inhibiting that within the tumor environment. And again, it's in trials, so it's not something commercially available, but I think always exciting to know that the science is looking for new things. In terms of immunotherapies, we have approved agents in clinical trials. In terms of conventional checkpoint inhibitors, Dr. Wang had touched upon ipilimumab, nivolumab. There are other classes of other available checkpoint inhibitors. It comes down to the uveal biology. It's just different. It just doesn't respond to these immunotherapy inhibitors as skin melanoma does. Multiple reasons for that. These are probably kind of the low-hanging fruit. The mutation burden, the mutation pattern is different in uveal melanoma. It doesn't express as much of that PD-L1 target for these drugs. And probably the biggest thing of all is the liver is liver sanctuary site. The liver is intended to not be inflammatory. You don't want a bunch of immune cells going into your liver and affecting the liver function. And in a way, it creates a space for these tumors to hang out and to grow unchecked. The biggest kind of first-line treatment that we have, and it's a very important point, is there is a drug called tebentafusp or Kimmtrak by branding that was proven to improve overall survival in patients with metastatic uveal melanoma that express HLA-A0201. A big point here is this is not the tumor that expresses this HLA phenotype. This HLA is a barcoding that makes all humans unique. The company in development had to pick the one that was most common and the most common broadly applicable population. So we see this HLA phenotype in about 40% of Caucasians. The way this drug works is it's basically pulling an immune cell next to the cancer cell through a particular protein linker called GP100. And it is a drug that has to be dosed almost on a weekly basis in order to have that effect. It did show a positive survival benefit. As you can tell, the curve still does have quite a drop, so it's not a wonder drug, but it is one of the best tools that we have for improving survival for patients with uveal melanoma that's metastatic and express the HLA-A0201 phenotype. While the study did not look at comparing it to two immunotherapies at the same time, when we do cross-trial comparisons, which we don't like to do, but if that's the best thing we have, we do, it still seems to be that tebentafusp is preferred over conventional immunotherapy to start with. And so this still remains the standard for those patients with the HLA expression. There are also immunotherapy options that are in trials. So this is with a drug called RP2. This is a herpes virus. The company took a virus, they found out which strain was really good at killing cancer cells and could also activate the immune system, then continue to engineer that virus and make it even more and more potent. The virus has to be injected into the tumor site, and the early trial data is showing that it not only helps the tumor site where it's injected, but also creating this immune response to shrink tumors, as you can see, like in the yellow circles outside of where the drug is injected. And it's given with conventional immunotherapy. It still is in trials, and it's something that many centers, including ours, will be offering for patients. In terms of cellular therapies, this is shifting quite a bit in terms of the delivery and the entire process. Many of you who are, and most of the uveal patients are highly informed. They always ask me about TILs. What about TILs? Can I do this? TILs are basically this process where you are going in, cutting out tumor, extracting the immune cells that have found their way into that tumor, but they just need more of them and more help to fight the cancer that they're surrounded by. And so the tumor is cut out, by a surgeon like Dr. Dan. They're sent off to a company. The company, this is for the commercially available product in skin cancer, but we can sometimes get that coverage here in the US for uveal melanoma. Gets sent off to the company. The T cells are then taken out of the tumor. They're expanded over a period of weeks, frozen, and shipped back. And then we put them back into the patient. It's quite an involved process. The responses here as well are not as good as we've seen historically with skin cancer, but there are trials now to understand maybe is it the type of cells, is it the cocktail of how we're expanding the cells, trying to improve on this process. Finally, talking about targeted therapies, which will be the last one I'll really focus on, and the clinical trials here. As we mentioned, the uveal biology is different, so it doesn't use BRAF as that driving force, but many uveal melanomas will express amplifications in GNAQ and GNA11 related pathways. And so there are drugs now that target PKC and c-Met to inhibit that driving process. So this is in trials with a combination of darovasertib and crizotinib, looking at the effect of that in HLA negative patients versus more conventional treatment options. And so it remains in trial phase, but it still is an option to consider. In terms of what else can we do? So a lot of patients just feel like, hey, I got this diagnosis, I had my local treatment, you're telling me I'm class 2, I'm praying positive on the tumor. I just feel like I'm just waiting. I'm watching and waiting for that scary day to come. And we're developing options. Dr. Wang had mentioned ctDNA as well. Uveal biology being different than skin, there's other ways to target the circulating tumor DNA. This is some data that was publicly available that was done by a company. It's it's not a commercially available ctDNA test, but it was specifically created for use on the tebentafusp trial, trying to understand which patients really benefit from tebentafusp. And we do see that those that had reductions in the ctDNA actually did better. Those are the patients that even if tumor wasn't shrinking on scans, they were responding in terms of the survival benefit. And we have research here as well to further build out ctDNA technology, specifically in uveal melanoma with the Harbor Lab. So putting this all together, and it's a lot, it's a full, it's really a multidisciplinary experience with a lot of providers and a lot of time. And we start with the local therapy. You see a provider, you determine, should I do radiotherapy? Should I have a surgery? Can I get the biopsy? I didn't touch upon this, but we also consider, if available, neoadjuvant trials where you're doing treatment before that plaque or that surgery happens to either shrink the tumors or try to improve vision outcomes, and particularly in patients getting plaque. After that happens, you move towards a risk-adjusted approach for surveillance, looking at the GEP and PRAME information from the tumor, and it's really a multi-year long game. We can consider adjuvant trials if something is available in that setting. And ultimately, whether you do a trial or whether you're just on surveillance, you are looking then for, at the time of progression, what do I do next? So based on the location of the disease, is it liver only? Is it outside of the liver? What is the patient's HLA status? You make decisions. Should we do tebentafusp? Should we consider a clinical trial? Or should we consider a liver-directed approach? While we would love any one of these initial therapies to be it, that's the cure, where the science is right now, nothing in the first line is a cure for this. Patients, ultimately, we have to think, this is a patch, the next thing is coming, what is it going to be? A lot of this is in my clinic is talking about opportunity and creating opportunity for next line treatments. It's not about finding the one treatment to end the whole story, but to actually find how do we keep things going. A lot of this depends on what are trial criteria. Sometimes you can do liver-directed up front, or sometimes you can't because the trial that may be coming online excludes the option of patients who've already had liver-directed. So there is sequencing here that's very much driving how to create opportunity and find the treatment that ultimately may work for someone. So our team is quite multidisciplinary. We have our ophthalmology team. Dr. Harbour leads this program. He is our chair of ophthalmology, a world-renowned ocular oncologist, and he's my mentor. Very, very fortunate to be able to work with an individual like himself. Dr. Margaret Lang French is one of the ophthalmologists, also sees these patients, does the biopsies, and then refers over to us. We have our local therapy team with Dr. Mike Topolsky in radiation oncology and Drs. Tenzel and Mancini, who are oculoplastic surgeons if an enucleation is something that needs to be discussed. We have Dr. Kim in our interventional and vascular team to be able to do these biopsies. Most of these times we always try to confirm the liver disease by biopsy before we make plans to do anything. Dr. Kim also is involved with the hepatic-directed or liver-directed therapy programs that we have. And really, this team, we have built this and to really focus on caring for patients in the DFW metro, but also to reach beyond North Texas. We have a growing trial portfolio, and we have a lot of really interesting multidisciplinary translational research projects across all of these specialties going on at UT Southwestern, and just a wonderful team of external collaborators. So I'll say thanks. This is Dr. Harbour pioneered this cooperative oncology group. Uveal melanoma is a small space. So the providers that care for this, the providers that know about the trials and are engaging with companies that are developing new strategies, it's a small group of folks. And we try to meet often and collaborate. And we love sharing patients and saying, hey, I have a patient that maybe would be better suited to come see you for a trial that you have. Of course, thanks to all the patients that trust us and give us the opportunity to care for them.